Welcome to Carolina Health Center's podcast, Access Matters Beyond the Exam Room. I'm Rachel Manor, and I'm here with Jessica Jacobs, our Director of Behavioral Health. And we like to try to create a space where we're going beyond the exam room, beyond symptoms, beyond typical medical talk, right? And we want to have real conversations, sometimes hard conversations. Today, we're going to continue to dive into our behavioral health series. And of note is that this behavioral health series, is running alongside a behavioral health column that one of our providers, Dr. Emily Young-Rizek, is providing to the Index Journal. This column is called Excerpts from the Experts, and she's contributing a series where she talks about behavioral health and some of the impacts that it can have on development from a pediatric standpoint. And so if that runs across, it's linked to our social media pages. We're on Facebook, we're on Instagram, Carolina Health Centers. And if that runs across, please check that out because that's really awesome too. But today, we are going to talk about something that is painful, that has reached a lot of different people in a lot of different ways, but it's very necessary to talk about. So we're going to talk about the rise in suicide and kind of what we can do about it from a community standpoint, from a personal standpoint. And we're going to try to ask some very candid questions. And to that, I would like to say that sometimes my verbiage is not, I'm not going to say anything way off kilter, but I also know that verbiage that is considered acceptable changes over time. Mm-hmm. And so if there's anything that I say that that has been deemed insensitive or offensive to anyone, let me know. And then let's talk about the correct way to say that and sure. Why. I don't project that that's going to be a thing, but also, who knows? Those things are easy. It can happen. And so we just want to have those conversations. So how are you doing today, Jessica? I just want to start there.
Yeah, absolutely.
Let's check in.
Sure. I'm doing well. Today it's been a good day. Been a good day so far.
Good?
Mm-hmm. Yes.
Awesome. All right. So we're going to start off with the basics. So we all have bad days, right? Sure. We have bad days. We have stressful moments. We even have not even moments. They can be times in our life where stress can seem more, just a little heavier, more present, more everywhere. Things can feel chaotic. What's the difference between that type of stress and then something that is more serious? And also, when those stresses, the tipping point of them becoming more serious.
Sure.
Right? Because those things that are every day can turn into things that are more serious, right? But it's kind of like two sort of different questions, but dive in.
Sure. All humans have stress, right? You're absolutely right. And there actually is even, we think of performance, right? There's a certain level of stress we want that helps us perform well. When we think of stress, there's stress around work, there's stress around deadlines, there's stress around projects at home even, right? Things that we think okay, these are good things. And so it's not that all stress is bad. But one of the things we talk about is stress management, right? So we don't talk about stress elimination because, again, as humans, we're always going to have a level of stress. We talk about, okay, how do I manage this and how do I manage it effectively? Now, when we start talking about these periods of maybe more temporary stress versus something that's more pathological or pronounced, we really do think about the duration of this. So is this a temporary stressor? Something happens in life. We wake up, our car doesn't start, and so now that has pushed back a few things. We're late. What are we going to do? Do we need a tow? Do we have somebody who can pick us up? All of those things, right? That's a stressful situation. But we can tie it to this specific stimulus, right, or stimuli. Whereas if you have something that is, you're finding that you're waking up feeling maybe more lower mood, right? It's pronounced. You think it's harder and harder to get out of bed. I'm more and more tired, sort of regardless of what my day looks like. I'm finding it harder and harder to engage meaningfully, whether that's with my family, my friends, my life, my work. And we're noticing, again, this impact on functioning because we have stress. We've acknowledged that. It's not that all stress is bad, right? But we're talking about, we're not seeing it necessarily go away or lessen. And we are noticing that the duration of it's longer. It maybe with those periods of time happen more frequently. And so we're feeling intense stress more frequently. And also the intensity of the feeling. And so, gosh, this feels really overwhelming. Whereas maybe previously we've experienced something like it and we're like, oh, okay, yeah, this is kind of a tough day. But we're noticing, gosh, I'm not doing well responding to these stressors anymore. And so I think really what you look at between just, oh, okay, I'm stressed, I'm feeling a bit down, is this continues. It's prolonged, and we're not noticing that maybe some of the things we typically do that help us feel better, maybe they're not working the same way.
Okay. So my brain's going in about 15,000 different directions now because I'm thinking of like personal experiences and things and the difference between how it feels to be in a stressful situation where you're just flustered because there's an inconvenience that has happened.
Sure.
But then there can be a span of time where, like me personally, the most recent thing I can think of is like there was probably about a 3-day span where it was in my chest, like physically, like you could feel like a fluttering, like your, what is it, your sympathetic nervous system, like your fight or flight response. And not that there's like a perfect formula for it, but at what point in that? Because I was like doing breathing exercises and doing the things, but like it wasn't going away. So like, what is the timeline on that someone kind of needs to look for to say, okay, what I'm doing isn't what I'm used to doing that usually works, isn't working. I need something else.
Sure.
Is there like some markers that people can look at? You know what I mean?
Sure. Well, if we look at it like as a clinician from a diagnostic standpoint, a lot of times, if you look at various mental health diagnoses, there's the question around like, okay, are these feelings, have they been present, daily for, a period of 2 weeks or more?
Okay.
Now, that is not me saying if you notice this really key change,
sure,
there is no,
give us 72 more hours.
Exactly. Right. Now, and I always tell people most folks have waited long enough, right? So if you're at a period of time where you think maybe I need help, yeah, probably.
Sure.
Because again, on average in the United States, there is from onset to treatment, there's an average of 11 years. So onset of symptoms to accessing treatment, it's an average of 11 years.
How? Why? What?
Yes.
11 years?
11 years.
That's the difference between being in like 5th grade and being like of drinking age. Like, I mean, that you like when
if you think about
it,
and if you think about all of the development that happens in that period of time, especially if we stick with like, okay, if you're thinking early,
right?
Because again, around, not to just throw out numbers, but I think these are salient numbers, right? Of like 25% of diagnoses, mental health diagnoses, have an age of onset of 14. And 75% by the age of 24.
Wow.
So as a clinician who works primarily with adults, the majority of folks that I'm seeing right now are, I think my current patient panel spans late 20s to early 70s.
Okay.
And so for a few of those folks, all right, fine. We're close-ish to that early 20s mark where it's 75%. But if we think of some of the folks who perhaps are, a little more towards middle life, that's a lot of years with a lot of symptoms,
right?
With very little treatment,
right?
And so, yeah, there is a significant delay.
Oof. And so stress, it's everywhere now, and it's it knows no age, right? Because you've got children, they've got school, they've got sports, they've got, whatever's going on at home or what might be going on with friends, and then you've got adults, same thing, and then you pile bills. Grocery prices, we all complain about things, but finances on top of that. And there's such a number of things. So when can stress turn into depression?
I think so.
Or do we not label it that definitively?
So, yes. I think the easy answer is yes, right?
Okay.
A lot of repeated, and I'm sure, we can have a debate in the comments. That'd be great, actually,
of course.
right?
Let's do it.
Yeah. But repeated stressors, repeated, if you think of repeated experiences that are really hard, that we don't necessarily know how to manage, that then take emotional bandwidth from us, that then turn into perhaps less healthy ways of coping, that then that cycle can be reinforced. And so now we're noticing an increase of symptoms. Yeah, I think a lot of mental health diagnoses, if we really would trail them back, it's like, oh, okay, there was a period of time in this individual's life that perhaps if a more targeted and early intervention were to have happened, we wouldn't see the development into this disorder.
Gotcha.
And so I think that's one of the pieces that I try to talk about so much with folks is there's a lot of really effective treatment. But a lot of times what ends up happening is we're using really effective treatment 17 years in to a diagnosis, right? So it's not that it doesn't work, but it's that we're 17 years into, pathology, and maybe we're only 3 months into treatment, right? And so I think sometimes that balance can be, it's hard to wait, right? When we feel really bad, it's hard for us to acknowledge, oh, okay, I didn't get here overnight, and so I'm probably not going to feel better overnight. But there are a lot of really effective treatments, and so I think I wish treatment was more accessible early, right? When we first started noticing some of these warning signs or symptoms of, oh, okay, we could actually do some really targeted behavioral intervention or cognitive interventions right here, and we wouldn't see this development later.
I did not know that. I am with the numbers, the amount of time from beginning, from like onset, if you will.
Like when you start looking at like more serious mental illnesses, it's often longer.
Wow. Wow. So what are some of the most like common misconceptions? Obviously, suicide is the extreme, right, kind of end of that, on that spectrum. But what are some of the most common misconceptions about suicide that you kind of encounter in your work?
Sure. From a patient standpoint or maybe like a community education standpoint or both?
Honestly, both.
Okay.
Yeah.
I think that, so when I'm sitting with folks who are talking and thinking about suicide, and I think, what you said earlier around like, help me know if I say something that's, kind of out of bounds, or maybe there's a gentler or kinder or more accurate way to say it. I always tell folks that I train is we don't have to be perfect in how we talk about suicide. We just need to talk about it.
Yeah.
Right? Because it is an inherently uncomfortable topic.
Absolutely.
And so typically when we're uncomfortable, humans, we are masters of avoidance when it comes to,
avoidance or watering down.
Yeah, when it comes to uncomfortable things, right?
Sure.
And the other, I went through a training actually around like how to teach and train adults. And one of the things the person said that has never left my brain is, right, as an adult, when we're in a room with other adults, we don't want to feel like the dumbest adult in the room.
Oh, for sure.
Right? And so I think that's really important when we're talking about a field and this is most field, but where language and acceptable language has changed,
Yeah.
right? And so then folks could get really uncomfortable thinking like, oh gosh, well, if I use a little, more antiquated language, will people think this about me, right?
Right.
What I say is talk about it, right?
Okay.
Talk about it. Now, as somebody who has more knowledge and experience, I need to have grace for folks who perhaps use, the different word, right?
Sure. What would be an example, if you don't mind?
Sure.
Yeah.
So actually, so I can remember actually at the beginning of my career, folks would talk about like successful suicides versus unsuccessful suicides.
Whoa.
Right? Or completed suicides versus incompleted suicides.
Okay.
And I think we don't even really have to dig into, or
Right.
dive into like how problematic that language can be.
Sure.
But also that language is really ambiguous. It's like, okay, what exactly do you mean by that?
Right.
And so one of the things that I tell people, and I'm sorry, I went a little off topic of your question there, is
No, it's
just
fine.
be clear in your language, right?
Sure.
So are we talking about suicidal thoughts? Are we talking about you're thinking about killing yourself? Are we talking about ending your life? Like, what are we talking about? That way it's very clear.
How are those different?
No, they're really the same.
Oh,
it's
okay,
just, yeah,
okay,
no,
okay.
it's just that they're clearer, right? So I'm
Gotcha.
not saying, okay, this was unsuccessful, or this was incomplete, or this was, I'm saying, are we thinking about suicide, or are we not thinking about suicide?
Sure.
Are we thinking about ending our life, or are we not, right? That's
Right.
what I need to know.
Okay.
And so the misconceptions, I think from a patient standpoint, when I'm sitting with folks, I've heard individuals kind of talk about, well, I think life would be easier for my family, right? Or individuals who think perhaps there would be like a monetary benefit to their death. They think of, well, my family would be better off with the money. Right. And so a lot of times that's the conversation that I'm having with individuals around. And if we bring in family and natural supports, I've never had a family member or a loved one support that idea or endorse that idea of, yeah, we'd rather have the money than have you. Right.
Sure.
And so I think there's this misconception of the place perhaps maybe individuals hold in others' life, the importance, right? Or maybe even the negative that the individual perceives that they're bringing in. And so a lot of times that's a misconception that I see with patients. I'll also hear a lot of times individuals say things like, this is a really selfish act, right? Or that this is a weakness. And it's like, well, this is, man, that's a tough statement right there.
Right. Yeah.
Because when we're really talking about suicide, what we're talking about is this pronounced emotional pain where this individual believes that one of the best options they have right now is to kill themselves.
Right. Right.
And that's a really heavy feeling and thought to sit with. And so, and the last kind of misconception, I hear is, okay, well, if somebody's talking about suicide, they just want attention. They're not really going to do it. And again, I do a lot of training, especially even with our new staff, and our staff in general on suicide awareness. And that can be met sometimes with a little bit of contempt, like, oh, they're just talking about it, right?
Sure.
Or they just want attention. And I always think about this. We all want attention.
Right.
Right? We all want connection. But asking for it by saying you're going to kill yourself, that's still a really pronounced way of going about getting connection.
Right.
And so that's still something for us to respond to.
Sure. Even if attention's what they're wanting.
Absolutely. And it's
They're
something
wanting
for us to respond to without contempt. Right. It's something to us to respond to with gentleness and with grace, as opposed to like, oh, well,
sure,
fill in the blank.
Yeah. So to that, I have two personal instances. The one where people, there was someone very close to me when I was a teenager who was talking about how they were suicidal and they'd attempted suicide. And I don't know if that's I think, is that the correct way of saying it? Like,
Yeah, they
still
attempted.
They attempted. Okay. I didn't know if that verbiage had changed. So they had attempted, and in a conversation, their reason was, it's not that they wanted attention. It's not, they wanted escape. They felt so heavy. They felt so bad that they couldn't see hope or anything better on the other end of where they were. And that was, for me, where that narrative changed in regards to, it's not a selfish thing. And so, and I've shared that with that point of view with other people before, and they've said, like, whoa, I've never thought about it like that. That it really is just, they don't sometimes know another way out. And then the other one to that, in regards to attention, even like you said, there's another person that, again, had attempted in a potentially violent way, and had reached out to his mother and said that, and she brushed it off, and that, like, well, he just needed it, he just wanted attention, or whatever kind of way, and that literally impacted his relationship with his mom and his other family members forever. Because there was never a moment from that point that he felt valued and seen or heard, right, by those people that are supposed to see and know and hear him more than probably anybody. So I think I think you definitely answered the question about the misconceptions, and how, yes, maybe it is attention, but it's probably not, they don't just want attention about that one thing, right? It's that they want to feel connection. They want to feel closer to somebody in some sort of way. So there was a statistic that came up that I got from the CDC, and this was specifically about teens, because we've seen a rise, right? And in teen suicide. And it said that, and this was from 2023, and we've talked before about how data is, slow. 1 in 5 teens had seriously considered suicide in 2023. That is wild to me. And we've also talked about the fact that if that's what the data shows, there are more. So that's more than 20% of teens. Potentially more than 1 in 5, right? It could be 2 in 5. That is absolutely crazy. And so what are the systems that need to improve? It's also, apparently now it's like in the top 10, right? Maybe even higher than it might be in like a top 5. I'm not sure. I don't want to start throwing things out, but I know it's in the top 10 causes of death for middle-aged adults. Right up there with things that you can't control, like heart disease, or things that are different sorts of ailments. Heart disease, cancer, things like that. What are the things that need to change? Big question.
I was going to say,
fix the world.
How much time do we have, right?
Right.
Access is something that's really important. Right. Now, I do think that we're having more and more conversations, right, around mental health, and we're having more conversations around the fact that asking for help is okay, right? I think one of the things that stuck out to me that's so heartbreaking about some of the story you shared, right, is asking for help is so hard. And so when that's not met well, it can impact the way that we think it will go for us in the future if we were to ask for help, and so that is, I always hate to hear that, right? Because if folks are asking for help, they're trusting you, they're being vulnerable, right? They're letting you into the aspects of life that, especially if we start talking, like social media and a little more curated, right? They're letting you into the real things in life. And I think that's actually a really high honor when someone's willing to kind of pull back the curtain for you. And so I think when we talk about systems, that need to change, there's a few things that I thought of, but the two things that kind of come to mind is, again, access and availability of providers, skilled providers,
Right.
but also connection within our community, right? So we have seen an increase in disconnection, and I think that contributes to, whether or not folks are accessing care. And so, right now we do not have enough mental health providers to meet the need. And that is not new. And unfortunately, that's not necessarily something that's fixed rapidly.
Sure.
I've been really encouraged. We've had, some really wonderful students and interns come through that I'm like, this is exciting.
We got 'em.
Okay, exactly, right? I can't wait for you to come back, right?
Sure. But it's time, right? It
But
takes
it is time. It is time. And you want folks who are well trained, right? You want skilled providers. And so, that's one of the reasons why we've been as open to having, interns and students come through, because we want folks to be able to see what the day-to-day work is like. But we also know that, and we've touched about this previously, right? The mental health care system hasn't always interacted, and the healthcare system hasn't always interacted well with all individuals. And so there's some real reticence around engaging with healthcare providers that I think is also impacting that access and that willingness to engage.
Okay. See, why is there an increase? Is the increase, and I'm sure it's twofold. But it's big and it's fast. And part of it I know is just in relation to we're paying more attention to it now.
Sure.
And we're trying to do more with it.
Yes.
But is it naive to say that, no, it really is a growing problem and we're just trying to grow to meet the need? There is more of a need now than there was 30 years ago. Is that fair to say? Okay.
Yes.
Why? Just insight.
Well,
again,
yes.
Not holding you to it, but from your professional opinion,
sure.
What are some of the things that are contributing to this?
I do think disconnection within communities actually is a big source of strain and stress among individuals, right? I don't think we can count that, right? I saw an article recently, and it was, it was essentially getting at, as an adult, do you know your cousins? Right? Do you know your more extended family? And I don't want to romanticize the past, but I do think there's a piece to that connection, that community that we do not have and we don't see currently.
We see somebody's highlights via social media.
Sure.
We don't see the real things,
yes,
right? Okay.
Right. And I don't want it to say, oh, okay, nobody knows their cousins. That's not what I'm saying, right? What I'm saying is we're not seeing it on the same scale previously. I think we could ask the folks in this room, okay, when's the last time you were at a family reunion, right?
Yeah, long time.
I used to go to those more, actually, when I was younger. And I'm trying to think oh, maybe I should get one together, right? But that disconnection, I just cannot state that enough, because humans, we're pack animals.
Right.
We are made for engagement, and we thrive in connection and engagement and in healthy relationships.
And as
systems.
introverted as some people can be,
Absolutely.
Everybody likes to feel connected. Maybe their connection circle is smaller than some other people's, but
I mean, we even see this from an evolutionary link, right? This has been a benefit and a necessity for humans all throughout history.
You had people.
Absolutely, right? And so with the invention of more and more wonderful technology, though, we have
pros and cons.
Exactly, right? We have to balance that out. There's a difference between being screen to screen, or face to screen, I should say, or face to face.
Sure.
There's a different feeling. A lot of individuals I talk to, they want they want to be seen face to face, right? And so sometimes for those more less frequent tele appointments, they're okay with. But again, they want to be in and share the same space, right? We also have more information and stimuli in our face than at any other point in history. Ever. Right? And so we know about not only those really sad and hard and scary things that are happening in my life and, my own life, but within those folks in my community, within those folks in my county, within those folks in my state, within those folks in my region, within my nation, within the world, right? And so that amount of information, it is hard to process. And it's hard for us to process, and without revealing our ages, our frontal lobes are fully developed.
Sure,
okay?
100%.
Yes,
yeah.
Solidly
And
developed.
once upon a time, the news wasn't as... So not only can we find all of it about everywhere, but we can find it all the time.
Sure, yes.
We can seek it out, even without seeking it, it's in front of your face. You can find news channels that are running all the time. When it used to be, 7 o'clock?
Yes, yeah, it's a 24-hour
Whether it was AM or
news.
PM.
Yes,
there are so many 24-hour, and you don't even necessarily mean to, yes, you can find those channels or whatever, but it's always there.
Well, while we've been talking, so my watch has buzzed a few times.
What's happened?
And exactly, right? And so I'm like, oh, this is interesting because I know it has to be one of a few things because I've limited certain notifications. But I'm like, oh, that's something's newsworthy is happening.
Sure.
And I think, that level of on.
Yeah.
But when we start thinking about kids who are still developing, right? That's a lot of information for a growing and developing brain to try to make sense of.
Yes.
And we've also experienced some really significant things as a nation, right? And without even naming specific things, like there has been a ton of
pick five,
yes,
right?
right?
I mean, there's so many
really significant things. And so I think we are seeing an increase in symptomatology of younger folks. And I think that it does just come at a really tough time of, the field not being able to meet that need, right? The capacity of the field can't, it is not equipped to meet, how many folks are asking, for help. And that's a really encouraging thing in some ways because in the last few years of my career, it's been the most significant demand that I've seen, right? People are saying, yeah, I'll go to therapy. Yes, right? But also as a provider, it feels, honestly, it feels really terrible to think like, oh gosh, okay, well, here's a wait list, or okay, I actually can't see any more individuals, right?
Right.
And so as a field, we have to get more creative on how do we increase access.
Right. So on the flip side of connection being important, to emphasize, I wouldn't even say emphasize, but the other end of that spectrum is being able to disconnect. And I guess technology is really where I go with this because I think back to, and you hear stories of bullying and things now, and it's online for some children, and I think probably most. But I think back to my childhood, and it was like, I'm sure those things happened, potentially even to me, probably blocked them out. But those things happened, but when you left school, it stayed there. Right? Home was a safe space. Nobody could still get to you via phone, via whatever. Nobody was texting either you or there wasn't another group of people that was consistently talking about something and just kind of like spiraling together about something. And so what is the value in that, and how can I know there's value in that, but how do we tackle that?
Sure.
Right? I mean, again, not expecting you to have all the answers, but if you have ideas, because that is a thing though, like kids can't get away from it now.
Yeah.
And that was part of the release of like, okay, I had a bad day at school. That bad day stayed at school.
Sure.
It didn't follow me home in my bedroom, and it wasn't just hanging with me all the time and buzzing on my wrist or on my phone. And how do we do that?
Well, we talk about increasing access in healthcare, right? While perhaps very intentionally limiting access to us.
Decrease access,
Right?
Yeah.
And it has to be intentional, actually. And this is one of the I have this conversation a lot, actually, because you're right. Our phones are buzzing, at any given time, especially if I'm sitting at work, I have, 2 cell phones, 3 screens, and my desk phone, right? And then on those screens, you could chat me either via Teams, you could email me, you could chat me in our electronic health record. Is there another way to get a hold of me? Yeah.
Via the computer.
Right.
Probably.
Probably, yes. Text, calls, and, folks, knocking on the door, right? And so that's a lot. There's a lot of access, right?
It's a lot of access.
And so when we think, and that, again, it's a lot for me as someone who is specially trained, actually, right? And so again, when we think about, okay, so fine, kids may not have all of that access, but, on their cell phones or on their iPads or tablets, and even among like gaming consoles, right? Ways of being connected, that it's almost like there isn't any of that reprieve.
Right, because there's Snapchat, there's TikTok, there's Instagram, there's Facebook. I don't even think younger kids really do much Facebook anymore, but if they do,
You're
it's
showing
there.
that your frontal lobe
I'm
is developed.
showing my frontal lobe is extremely developed, all the way developed. And so but there are probably things I don't even know about.
Right.
Where kids they can get to you.
Yes. And so I think this is one of the hard parts as parents, right? We have kids that
I have a toddler and I'm terrified.
Gonna say, they're close in age, right?
Yeah.
And so when you move anyone from a preferred activity to a non-preferred activity, what happens?
We're gonna fight about it.
There's really strong advocacy.
There's pushback.
There is very strong advocacy around, I want this and I should be allowed to have this access because of, right?
Why not?
And I think that's where we as parents, and as caregivers and as individuals say, okay, I'm making this choice because it actually is for your health. Because you should look at a flower in real time, right? You should go outside.
Feel the sun, feel the grass.
Absolutely, right? But it's not easy, right? And so in no way am I saying like, just turn off.
But also we have to set the example, right?
We do.
Like I have to put my phone down and go outside and feel the sun and feel the grass and look at the flower.
Yes, absolutely. Exactly, right? Be very intentional about it.
Yeah.
Because it is easier for us to kind of get into that like scrolling,
doom scroll.
Absolutely.
Yeah.
And for us to intentionally do that though, again, like make the decision and put things in place that help make that a reality. And one of the things we know, like behavior modification 101, right, is if you are going to go and modify a behavior, it is going to get worse before it gets better, right? And so if you as a parent, or caregiver make the decision, hey, so it's an hour before bedtime or 90 minutes before bedtime, this is the dark zone in this house. Know that for a while it will be a very dark zone in your house, okay? There will be a lot of stress, there'll be a lot of pushback.
Yeah.
And then it does get better. but we're going to have to
You have
talk
to
about
create the
coping
routine
skills.
first.
Okay, we're going to
Sure.
talk about coping skills of managing
Yeah.
that distress,
Yeah.
right? But there is some real benefit to that disconnect because, again, as humans, that's not what we're used to. Again, if you just think about us in a historical context, we are not used to this amount of access all the time.
No, not at all. All right. So coping skills, going to write that down. We'll cover that on our next episode. So warning signs. So something that you hear very, very often is when, after a tragedy, when people say, oh, but they seem fine, or they were so happy. And of course, I think especially when the happiness thing, we all go to the beloved Robin Williams, right?
Yeah.
And people of saying that they were always making other people laugh, or and that's not to keep it up here in the realm of Hollywood, but people we know.
Oh, sure.
And why is that the case? That's a pretty common, right? Or maybe those stories just get more attention because they're a little bit more of a blind side.
Well, and I think maybe following that trail real quickly is they may also be a bit more palatable to talk about, right?
Okay.
So, they may
Okay.
be a bit more of like, oh, well, because it brings a little bit of comfort even to the person talking about it, of like, this, I remember this really happy moment, or I remember this, right? And so it's a little easier.
It also
maybe,
releases you of responsibility,
perhaps,
because maybe you didn't. You don't have to hold yourself responsible for it
Sure.
because there wasn't,
What I also like to ask is, what is it that you expect folks to look like? And I think if we all slowed down and really thought about this, like, okay, well, what is our caricature of, or what is our perception of, if an individual is thinking about suicide, what do they look like?
Right.
And then we need to evaluate, like, is that
It's very much probably an archetype.
Absolutely.
Yeah.
But also, sometimes we do see a bit of a positive mood shift from individuals because, like we talked about earlier, right, they're experiencing very significant emotional pain. And so if they have made this decision to end their life, they may, in fact, feel some relief. And so you may see this mood shift into a more positive realm than maybe what it has been previously.
Okay.
And so that could be a reason for it. But I think it kind of ties into, like, what are you expecting this individual to look like? Because and I say that with all gentleness, because I think when we think of disease progression, typically there, if we think of advanced stages in other diseases like cancer, there are some very pronounced physical appearances, right? And so perhaps we're thinking, even though, it's still pathology advancement, maybe we're thinking that it should look like this over here, but that actually is just not true for this disorder. Or I should say, it's not always true, right? It doesn't follow the same paths as maybe what we typically think about when we think about pathology progression.
Okay. So then what are some warning signs that we should look out for friends and loved ones that, might help us ask?
Yeah. And so look for those mood shifts, right? I like changes in behavior, right? So if we say, if we notice that someone's mood has changed from what is typically their norm, their baseline, kind of within normal limits,
like over
for
a span of time, we're kind of like, hey, I've noticed that over the last month or so.
Sure.
Okay.
Yeah, or we notice changes in their behavior, right? So maybe somebody who was more apt to say yes to invites, we're seeing their life get a little smaller.
Okay.
Right? So it's work home. We're not seeing them engage even as much in whatever realm we see them. So if we just, talk about work, maybe they don't spend as much time in common areas, right? As they used to. Maybe they don't go to, those
drawing.
Yeah. increase in maybe dysfunction in other realms as well, interpersonally, financially, maybe at work, at school, right? We're seeing again an impact, a negative impact in their life. Perhaps an increase in substance use, right? Also, those feelings like we talked about earlier, right? So those feelings of hopelessness, those thoughts of being a burden to others, right? Of, folks, that hopelessness of like, I don't think it's going to get better. And, honestly, you'd be better off without me, right? That sort of line of thinking. We do also take note of, okay, so has this individual attempted suicide in the past, right? Is suicidal ideation something that they've spoken about previously? Is there any family history of suicide as well, right? So we're asking all of those questions when we think about it, but also perhaps searching for means. And so, someone accessing more lethal means, whether that's a substance that would be lethal, and or an individual who maybe has never been interested in owning a firearm, and then now they're really adamant about it. Kind of coupled with these other warning signs.
Sure.
And sometimes it can even look like making provisions for things that they really care about, things and people, right?
Sure.
So,
making sure my family has all my passwords to certain financial information or things like that.
Absolutely. Also making, the provisions for their animals, even, right?
Yeah.
So again, making sure their kids are set up, their family, their animals. Sometimes even giving away like really key possessions, right? I know you've always liked this necklace that was my grandma's and I want you to have it, right? And so those moments, if that was
in conjunction with other things,
right? Yeah, because I always tell people, because a warning sign can actually be like estate planning, which is actually really responsible.
Very responsible,
right? It's very
Like
responsible.
don't not make a will.
Exactly.
Right. Like be responsible and gift someone the necklace, but but there are other things to look out for.
Right. If it's in conjunction with these other things, right? And what I'll tell people is I would rather live with the awkward feeling of asking if you are thinking about suicide, and maybe have you think like, wow, Jess maybe needs to take a vacation, as opposed
You'd
to
rather
me
think I'm a little off.
Absolutely. As opposed to me wishing desperately I had asked you.
Yeah. Okay, so then we see the signs. How do we approach?
Sure.
I mean, I'm a bulldozer sometimes, so if there's someone that like I'm a bull in a china shop. And so if there's someone that I care about and I think something's wrong, I'm gonna talk to them.
Sure.
And I'll be like, hey, like I'm gonna probably say the thing, but also knowing some people,
some folks
might
are more
shut
delicate.
down. Absolutely.
Yes. So one of the things, why are you checking in with them? And so think about, why is it that I feel this need to check in with you? And so if it's around some of those behaviors that we talked about, hey, I've noticed that you haven't gone out with us the last few months. Sure. Is everything okay?
Yeah. Like we miss you.
Absolutely.
Yeah, we miss you around.
You've just seemed more down lately. I'm worried about you.
Sure.
And again, you can put it on you, right? Yeah. I'm worried about you. Are you okay? Or even a gentler of, I just want you to know I'm here. If you need
to remind people,
let me know, right? I'm happy to listen.
Right.
And, you can, depending on who, because it doesn't need to be my style of things, right? So I'm not a very touchy-feely person.
Sure.
Right? So if I come up to someone and I'm like touching them and staring into, like, I'm going to feel weird too.
Really weird, right? Yeah.
But there's
I'm gonna be like, what's happening?
Exactly, right? Like, why are you
not going to be comfortable, and everybody's going to feel weird.
Correct, right? And so it doesn't have to be like, okay, what Jess said is I do that. No.
Sure. And you don't have to
again,
like have a whole thing where you're like, you
No.
sit down. Like it's literally kind of a pop in sometimes and just
can be,
setting the stage.
absolutely, right?
Opening
Yes.
the door and they can walk into it later maybe, but just let them
Correct.
know like, hey, I'm here. Like it doesn't have to be like intervention style.
Correct.
Right?
Yes.
Like that's
no. And
probably
it doesn't-
terrifying.
Sure. And it doesn't have to be anything super over or again polished or smooth or
Yeah.
any of these. You can, you can stumble. You can say,
Yeah.
hey, I feel a little weird, okay? But I just wanted to
Right.
check in with you.
Right.
And say,
Not
I
trying to
care
make this
about
weird,
you,
but like,
and I'm worried.
yeah.
And are you okay?
Sure.
And now, if it's someone who I know them and I'm noticing these changes, I'm going to push as well. Because like I told you, right, I would much rather live with perhaps somebody feeling a little miffed at me even, right? Or feeling like that was weird.
But they're
Than,
here.
right. But then me sitting there thinking like, I wish I had said that, right? And so maybe I ask, I've noticed that you seem a little down lately. Is everything okay? Yeah, I'm fine.
You sure? Right.
And again, if I know them,
But if you
I'm
know
gonna
them, and that's the
say,
thing, if you're close to them, they're your family, if you're around them enough to notice that change in behavior, you know what you're seeing.
Sure, absolutely. And I
And
think
you
that
probably
piece,
know them
yes,
close enough to be able to push a little bit more and be like, you sure? Okay.
absolutely.
Like, and I'm probably the person that would also walk away letting them know I'm in slight disbelief. Like, okay, well, if you say so, but.
Sure. When I think,
Yeah.
being genuinely who you are,
Right.
and trusting yourself in that moment, right? Because again, a lot of times, so when I do trainings with our staff, it's the only time when I'm training that I demand participation. Okay.
love that.
And I make folks pair up with each other, and all they say, right? No, everybody just asks the question, are you thinking of killing yourself now? Nobody has to answer, right? But everyone has to ask their partner that question. And one of the things that I always, encourage folks to do is I'm like, I want you to think about what your face looked like, right? Because again, you don't have to be perfect, but if you're sitting there being like, are you thinking about killing yourself now? Right? It's very incongruent, right?
Sure.
Or if you're trying to present in this way that is not you.
Doesn't feel comfortable,
right?
yeah.
Exactly. It does not have to be perfect.
Right.
You just have to be able to ask the question and convey to the individual that you're willing to help. Right? Again, help is not ending with you. Right? But it's just like with CPR. It's everybody's job to respond. It's my job to treat, actually. Right?
Yeah.
But it's everybody's job to respond.
Yeah. All right. So one thing that I do want to kind of like point out that you've hit a couple of times, but I haven't directly said, suicidal thoughts don't always look like, and I think this is the thing that people can think of. They feel like it's someone plotting out how they're going to do, how they're going to do it, how they're going to go about it. And it's not necessarily that. It's things would be better without me.
Yes.
It's this would look differently without me. This person would be better off or whatever. And then acting, maybe they don't know exactly what it's going to look like at the end of it, but it's that removing themselves from a situation mentally before physically.
Sure. When I think, you're talking about the difference between suicidal thoughts and a suicide plan.
Sure. Okay.
Right?
Yeah.
And
And
so-
I think, okay. So yes, there's the verbiage,
Yeah.
two different things, but I think that sometimes people can maybe ignore or not
Sure.
the suicidal thought
Yeah.
because it doesn't look like a plan.
Sure.
And so, please, speak to the
Yeah, I
difference.
think that's that's an interesting comment, right? Because again, as someone who's like as a trained clinician, right? I'm like, oh, okay, yeah, these are separate things, right?
Right.
Of course, I would attend to these thoughts because thoughts precede the plan, right? And
Sure.
and so I think that the thoughts are enough to respond to.
Right, but the
right?
thought,
Yes.
but my point is that the thoughts don't look like the plan.
Absolutely.
And that
Right.
those are separate. And I
Yes.
think sometimes because honestly, I don't think I have thought of I see the plan as the suicidal thought. And so when you said that was actually a light bulb for me that it was
Sure.
like, oh, no, this is the thought. It's just the envisioning without me in it.
When a lot of times when we're doing, you know, as clinicians, if we're doing a suicide assessment, right? Because, you know, you come to the doctor, there's different screenings. And so, you know, some of the screenings ask, have you, you know, do you have thoughts that you would be better off dead? Or, you know, something like that. And if when folks answer, you know, a lot of times that turns into either a warm handoff with my staff or a referral to my staff. And so if we walk into an exam room because of suicidal ideation, or we're going to ask very directly about that. Okay, so, you know, I noticed the way you answer this, or are you having thoughts of suicide now? And a lot of individuals are, you know, at the doctor maybe for a different reason, and they're like, well, I have thoughts of suicide, but I'm not having them right now. And so, and there's a distinction there. And, you know, if folks, I'm going to ask, do you have a plan? Have you thought about how you would kill yourself? Have you thought about how you would end your life? Because one of the other things we're continuing to, you know, assess for is severity of risk, right? And so if an individual has thoughts, there's a plan, and they have access, then that's higher risk.
Those are all the parts to the
Right. And so it's like, okay, is this an individual that needs a higher level of care? Or is this an individual where if we put some very real and robust safety planning and access, get them access to treatment, that actually continuing to manage their mental health concerns in the community is very appropriate. And so, you know, not everyone who comes in, and I think this is actually really important to say, is just because you come to the doctor and you say, yeah, I think about suicide, that doesn't mean that we're going to say you need to immediately go to the hospital.
See, I think that's a very important piece. Yeah. Because a lot of people, I think, feel that way.
Yes,
They're immediately
absolutely.
going to put me over here, and it's going to, like, you know,
because
DEFCON 1.
Right. Well, and suicidal ideation is something we can manage in the community, and it's something we can manage well in the community. Again, there's effective treatment, right? We don't, and this is a fault of the field, we don't talk about the fact that, you know, what we do is a science. It's how we apply it is the art, right? And I think sometimes folks kind of forget, you know, they think about psych or behavioral health and they're like, oh, yeah, that. And it's like, no, friends. Very rigorous studies here, thank you. And so there's effective treatment that also can be very short term. Because again, you know, a misconception I think that we have is, oh gosh, okay, well, once you know, are in therapy, you're in it forever. You know, there's a lot of folks who are in therapy maybe around 3 months, right? There's a lot of folks in therapy for 3 years. You know, again, different needs.
What do you need?
It is exactly, it's what you need and what
Maybe your needs change.
And what your insurance will cover, unfortunately.
Unfortunately,
right? But it is about responding to the need there. And so again, just because you say, yeah, I think about suicide, I say this in not a minimizing way. Yes, you do, and so do hundreds of thousands of your fellow Americans. There's no shame in this, right? We can talk about this. We can create a treatment plan. If psychopharmacology is something we need, we will absolutely loop in your primary care provider, right? And so then now we have this interdisciplinary team, because other health conditions are exacerbated by untreated mental health. Right? And so, you know, sometimes we're not seeing the progression we would want in other areas because the depression hasn't been treated. Right? And so we're over here, you know, our colleagues on the medical side are over here valiantly trying to treat, hypertension and these other concerns. And it's like, well, if we were able to tackle this major depressive disorder, though, and really get a handle on it, we would see some increases in benefits other places. And so I think that's something that's just so important, because it's not this fixed thing of, oh my gosh, you said suicide, and so now I have to send you somewhere else.
Right.
No, here, unashamedly,
Yeah.
my priority is keeping you safe,
Sure.
right? And so I always tell individuals, I believe I can help you if you're not dead,
Right.
right? Like
Right.
that's
If
the
you're
piece.
still here,
If you
we
are
can do
still here,
this.
we are going to
figure it out.
We are going to figure it
Yeah.
out, absolutely, and we will pull out all the stops,
Right.
right? And so if it's imminent risk, yeah, the most appropriate place is a hospital or setting that can help keep you safe.
Sure.
It helps keep you alive,
Right.
just like any other crisis.
Right.
If I notice somebody,
If I'm having a heart attack, send me to the hospital, please.
exactly it,
Right?
right? If
Yeah.
it's an emergency, it's an emergency. I don't care if it's above the shoulders or below,
Right.
right?
Right.
I could go in on that for a long time, so I'll stop myself. Okay.
No,
yeah.
that's fine. So and I know I've said this, but it can almost sound trite to use the phrase like safe space. But how do we create? How do we cultivate that safe space with the people that we spend our time with, so that
Sure.
even if we aren't the one who goes forward to ask, maybe we don't initiate the conversation, but how do we help cultivate that safe space where people do feel safe, feel
Sure.
comfortable, feel open and welcomed?
Yeah. I think
do that,
it starts
have those
because a lot of times if
conversations.
we think of safe space, we think of location, right?
Yeah.
And so I like to shift the focus to like, I'm a safe person,
Sure.
right? And so the spaces that I enter into, they immediately become a little more safe.
Sure.
I won't say they're totally safe, right? Because
Well, yeah,
there is
external,
clear,
yeah.
right? But starting with us, right? So one of the pieces I was thinking about this is, so growing up, my mom was a seamstress, okay? And so she made me a lot of really great clothes, actually. But what was always really funny is my mom would show me these patterns, and she would say, "Just do not look at like the fabric, just look at the pattern." And it was really hard for me to suspend whatever, because whatever the model was wearing, I was like, I'm not wearing that, right?
She saw the shape of
Yes,
it, the lines.
right.
Yeah.
So in this, we all have judgments.
Sure.
We all have ideas about what things are, right? What they will be. And so the problem actually is not that we have judgments. It's that, do we evaluate them? Right? And so a lot of as humans, a lot of what we learn comes through experience.
Sure.
But it also comes through where we grew up, where we were trained, all of these different things. And so when we show up with our judgments, the thing is, there are judgments in this room, okay? Because there are humans in this room.
Sure.
However, just because I have a thought doesn't mean it's fact,
Right.
right?
Right.
And so for
Your
me,
brain's just going to do.
absolutely, right?
Right.
Initial thoughts, we have no
Yeah.
control over. Subsequent thoughts, we do, though, right? And so I actually become a much safer person if I'm willing to evaluate, I had this response to this person
Why?
telling me these
Yeah.
things. I wonder why.
Why do I feel that way about
Absolutely,
that? Yeah.
right? Oh, okay, this interaction left me feeling or thinking this. Is that accurate? Do I agree with that thought that I had, right? And I think when we're able to reflect on that,
Self-reflection,
absolutely,
yeah.
and have some awareness of the fact that like I actually don't have to like everything.
Yeah.
Okay. I just need to not exert my will on other things, right?
Sure.
That helps me become.
It can just be.
Yes, right. Absolutely,
Yeah.
things can be. That allows me to become a safer person.
Okay.
Right. That allows me to build space that an individual doesn't have to feel judged coming into my space because again, my thoughts and my immediately. I don't have to act on them, right? What I need to know is, or what I need to have that other person know that if they bring me something, I can help, right? Especially in this round, like when we think about like from a suicidal like crisis, right? Or a disclosure of like, hey, sometimes I have these thoughts. Okay, well, if somebody came to me and was telling me all about their like liver issues, I would say like, that does not sound good. So we should get you to,
Yeah.
right? if somebody came to me with suicidal concerns, I would be much better equipped to say, okay, what we can do is,
Yeah.
right? But again, liver concerns, who we should get you to is,
Right.
right?
Right.
But that may look like me sitting with them and saying, oh, actually, do you have my chart? Can you request an appointment? Or, hey, do you know the phone number? Right? Like, it may look like me connecting them to care. And so, again, it's all of our jobs to respond, but it's other individuals' jobs to treat in some of these realms.
Okay. So how can parents, and I know peds isn't necessarily like your realm of where you typically like are. How can parents have those conversations with their kids, or how do they create that space? How do they be that safe person or identify that safe person? Because kids are,
Sure.
We'll say teens. Teens are teens. They're not going to, they think their parents don't know anything. I have a 3-year-old, and sometimes I think she doesn't think I know anything, right? And so it's only going to get better. But what are some of the tools that parents can have for that?
For having those conversations?
For having those
Sure.
conversations or seeing those things, those behavioral changes in their kids. Also, teens are hard, right? Because
Absolutely.
behavior is just wacky anyways. But
Well, there's a lot of development going on, right, at that period of time. Yes.
Nobody can handle all of that.
Yeah, right. Well, and I think kind of like I said earlier, right, of like humans, a lot of what we learn is through experience. And so if we've set the precedent as caregivers to say, like, it's okay. Like, there are no topics necessarily that are bad or off limits. We just may choose where we have those conversations, right? Or yeah, there's going to be certain things that are maybe adult conversations, but you can always come to me and share, right? But that means that if our kids are coming to us and sharing concerns, then we need to meet those well, right? As opposed to like your friend, what you talked about earlier.
Yeah.
Because the thing to remember is the problems that someone else has, they may not seem that significant, maybe even to me, but they're very real to them.
To that person, right?
And so the last thing we want is
It's all relative.
absolutely right.
Yeah.
And our kids, they're coming to us with their concerns, and so being attuned to that, right?
Sure.
Modeling and setting the precedent of when you bring me something, I'm with you, right?
Yeah.
When you bring me something, we can manage it together. And if we can't, we know who to go to, right? I think that's one of the really important pieces about having providers and healthcare professionals that you care about and trust, right? Because, okay, well, I don't know. I think maybe it would be really great if we go and talk to Dr. Bray about that, right?
Right.
I think this is now something that we should loop in we should talk to Victoria over at the Children's Center. We should talk to our therapist about this, right? Or maybe, what about talking to a therapist? Is that something you'd be open to, right? Us bringing up these things that, a lot of times our generation, it's not that folks came to us and said like, well, have you talked to a therapist about that? I grew up in a place that had very little when it comes to healthcare access. And so, I didn't even see a counselor, right? And I just mean visually be like, oh, that person's a therapist.
Right.
Until I was in college, right? And so the idea of going and talking to someone was not realistic.
Right.
And now again, the increase that we've talked about in access, really important, but bringing that to our kids too. So if they bring a concern to us listening and saying, helping them cope or problem solve. But then also saying like, if this feels really big, maybe we should add in some people to our team, right? You can always still come to mom, but maybe we build your team more, right? Also, though, the way that families handle conflict, disagreements, big situations, right?
Yeah.
So maybe it's not even a conflict within the family, but
a challenge, right? How do folks, how did the household function during, day 5 of no electricity and during Helene, right? How was that going?
Right.
How did we
Right.
manage being a little too warm or, not
Yeah.
watching TV or, things like that? Because
Yeah.
again, a lot of times what we pick up is from, who we grew up,
Yeah.
who raised us.
You make your assumptions about how they're going to respond based on how you've seen people respond.
Yes.
Yeah.
Yes. And
Yeah.
so again, with kids, your kid, right? And so there are some kids who are just old souls, right? And they will say language and words to you that you're like, how do you know it? Like, have you been reading a thesaurus? Like, what is happening, right?
Sure.
And so with those kids, it may be a bit of a more direct conversation, right? So if they ask a question, or if unfortunately, that's something that happens within the community, having that conversation and saying, like, yeah, this person was, experiencing a lot of really intense emotional pain. And this sometimes is what happens, right? Other times reinforcing, it's just like if your ankle or your foot hurts, you come to, so-and-so and I, and we help you out. That's what we're doing. We're just doing it with your brain, is all, right? And so kind of scaling that language based off of the family culture, but also the child's developmental age and what they understand. Because also kids, man, they ask really, I always joke with people, like, I started my career in pediatrics, but like, they're terrifying, right? And so there are questions I'm like, I'm not prepared for this question. And so kids will ask really fun and insightful questions, but also really anxiety-provoking questions. But also always remember you can go back to it. So let's say you fumble it.
Right.
All right.
Or even if you don't know the answer from the start, you're like, let's look into this.
Absolutely.
Yeah, go back.
No, you can always go back. There's very few
Prepare
things.
your answer
Yes,
and then come back.
absolutely, right? There's very few things that aren't unfigure-outable,
Yeah,
right?
yeah.
And so we can always go back and say like, hey, when we were talking about this, I just wanted to, do you have any other questions, right?
Yeah.
And keeping that line open, even if you don't go back with any more information, but just say like, I really love that you came to me with that.
Yeah.
Do you have any other questions?
Yeah.
Because it lets them know that the next time they do have questions, well, they can come back and ask.
Right.
Now you just have to be prepared.
Sure. You got to be ready. If you're going to keep that line open, you got to be
That's
ready.
right. Yeah.
But also, if you do say something and then in hindsight, reflecting on it, you wish you had said it differently or something, acknowledging that.
Absolutely.
Being like, hey, when I said XYZ, I don't want that to sound wrong, or I didn't want that to come across a certain way. So let me make sure that, like, let me clarify and to make sure that that message is received.
And or, hey, I actually learned something new.
Right. I was wrong.
Yes, exactly. Let me let you know.
Yeah. Well, if somebody, parent, adult, teen, whoever, if someone's listening or watching right now and they are hurting or wanting help, what would you love to say to them, and what resources would you love to tell them about?
I think it's really important to know burdens are so much heavier when they're carried alone, right? And so, because I think sometimes people will think like, oh, well, this has been said to me, well, you're a therapist, you have to care, right? And the thing is, like, I'm a therapist and I get to care, right? Like, I get to sit with you.
You don't have to. You've chosen to.
Correct, right? Absolutely. Right. And like I said earlier, like, folks bringing in their pain and their experiences that are really hard to process and their vulnerability and their trust, I don't think there's a higher honor, right? I don't think, like, as a human, like, sitting there with someone, like, again, the honor that I feel when people are willing to share that, it's not a burden, right? It takes a lot of strength and bravery to be able to sit and say, I'm really struggling with this. Or, you know, my brain is sometimes, and my mind's a scary place. And I wish it wasn't.
Mm-hmm.
Yeah. We can work on that together.
Mm-hmm.
I think the other piece is I won't tell people to feel hope when they don't, right? Because it's just like me saying, oh, you need to calm down. It's never worked to help someone calm down, right?
Sure, ever.
And so I think the thing is sometimes you don't feel the hope.
Mm-hmm.
And that's okay because I'll carry it for you,
Mm-hmm.
right? I'll carry it for you until you feel it,
Mm-hmm.
right? Because like I talked about earlier, it's a science, right? It's not just me sitting there thinking, ooh, this is what we're going to do today, right? No, what happens is it's a partnership because you come in and you sit with me or my staff, and again, we're humans who want to be there. We want to be there with you, right?
Yeah, y'all chosen this. Y'all put a lot of time into this. You could have backed out at any time.
Absolutely. Most of us have a lot of time and a lot of debt tied to this, okay? And so, like, we are
Right.
happy to be
But
here.
a lot of heart, so much heart.
Absolutely. And what we do is we work together to figure out, like, okay, what are the areas that we need to tackle that help life feel a little bit more bearable? And, you know, we're not going to sell you a bill of goods of like, okay, this will happen in 3 sessions or 1 session or 15 sessions. No, right? What we're going to do is we're going to look at very clear metrics of things that maybe aren't going the way we want them.
Because
right?
again, it's a science.
Exactly.
You
Yes.
don't have an exact timeline, but you know that the result is there,
Yes.
waiting somewhere.
Correct. Well, and the thing that's also really nice is our practice and work is married with the medical providers. Yeah. And so, you know,
Yeah, that's
the
big.
most effective treatment is a 1-2 punch. Therapy, medication.
Right.
Right? Again, oftentimes these 2 components are time limited, right? And so folks, you know, are start medication and they're going to therapy in conjunction, and you know, perhaps they taper off of medication, still go to therapy. Perhaps they stop therapy, but they continue with medication, right? But a lot of individuals who go to therapy and also are on medication, they're not on that regimen forever, right?
Right.
It's what, you know, a lot of times what medication allows us to do is it frees up enough bandwidth for us to do some of the
do the
emotional
work.
work, right? And to make some of the behavior modifications that we need to, right? I recently started training and working out again, okay? And it's been really funny to me because I used to, you know, very, you know, athletic, very
I
involved in
crept your
all of
Facebook
these.
page when you first started working here, and you did strong women competitions.
I
Or you at
did,
least
yes.
did one. Because
yeah.
I remember seeing photos.
Yes,
There was
yes.
at least one in there.
Correct, right?
Yeah. Yeah.
100 years ago,
Had to
right?
throw that in there.
Yes. And so
It's pre-kids, yes.
yes, it was. You better believe it. But it was, you know, what was really interesting is, again, my training doesn't look the same as it used to.
Sure.
Right? It's almost like we planned this and we didn't, right?
Right,
But it doesn't
right.
look the same.
Yeah.
But there's also been kids, some moves, a few factors, right? That factored into what I had the bandwidth
Right.
to do, right? And so a lot of times that early treatment is really trying just to get us to a place where we can engage in some of these activities that we actually feel really good about, right? That even though, today going down the stairs is a little harder, right? It's still a good feeling,
Right.
right? But previously, I wasn't making time for that, right? Previously, I wasn't in a place where I even had the, honestly, emotional or physical bandwidth to do it,
Yes.
right? And so as a therapist, a lot of my job is to hold that hope and to hold that knowledge that working our treatment plan, we will see benefits.
Sure.
It just won't happen, you know, maybe in this really condensed
Well, and it doesn't
time
look the
frame.
same for everybody.
Exactly. Yes,
Some people may less time, some people
Yes.
more time.
absolutely.
And that's just human nature.
It is.
That's just life, right?
When it depends on where you are, right?
Yeah.
So if,
Yeah.
I think sometimes we really forget like the fact that how much sleep we get the night before really impacts our emotional state, right? And so if we have a stressor that, we got a full night of sleep on, we're like, oh, okay, yeah, that's a minor inconvenience. But if we were up at various points throughout the night, all of a sudden this stressor seems
Because we
much
sat there and we
larger.
thought about it all night, and it's just
Absolutely.
consuming our entire brain.
And so it's
Yeah.
like, okay,
Yeah.
through like if sleep, because sleep is something we talk a lot about with individuals, disrupted sleep really impacts our mood, right? It really impacts our functioning. And so if we can get even, that more online, that's a significant benefit. Folks often see a very significant mood shift from more regulated sleep, right? So I think sometimes folks don't necessarily realize all of the realms that therapy touches, right? Because we think like, oh, okay, yeah, we're going to go in there and talk about our feelings.
Right.
And yes, we are. We really are. We are going to talk about your feelings some, right? But we're also going to talk about your sleep, and we're going to talk about your relationship, and we're going to talk about your suicidal thoughts, and we're going to talk about your medication needs, and we're going to talk about lifestyle modification, right? We're going to talk about all of these things.
So resources for people
Yes,
who may be having these. There's a national hotline.
sure. And, I think a lot of times people kind of think of hotlines as like, oh, it's a hotline, right? And
Yeah, I think and so I
Yeah.
even cringe slightly using the word hotline. They actually call it the lifeline, though, right?
that.
I
Yes,
think
yes,
they,
yes,
I
they
think they
do.
call
Yeah.
it the lifeline,
Yep.
which I do love. But
the
let's talk
thing-
about that, and then like what that looks
Yeah.
like, because you probably know more about it than
Well, one of the things that I think is actually really beneficial about a hotline or a lifeline is there's an anonymity there
Yeah.
that can be really freeing, right? So, and also you pick up the phone and you call or you text it, right? And so,
Right.
especially when you're talking
And
about
it's
access.
988.
Yes,
Yes.
988.
988.
And especially when you're talking about access, right? And so a lot of times things seem maybe a little heavier or scarier in the dark, right? They seem a little heavier or scarier at
Everything's
2
bigger at
a.m.
night. Yes.
Yeah, right?
Yes.
That's a resource that's available,
Yeah.
right? And, one of the things is, so when you go to a care provider in the community, there is that. Maybe sometimes folks have a little bit of a concern of like, okay, am I going to run into them at Food Lion or Publix or Dollar General or, and you
Right.
might, right? You
Right,
just
right.
might. And so if that's something that is really, kind of keeping you from engaging, there's a few things I could say to that. But, a hotline is a great option because you don't know the person on the other end, right? And so sometimes there is a freedom in getting out and talking and having a conversation with individuals that you don't worry about seeing anywhere else.
Right.
Right. And so, and the individuals on those hotlines, they are trained in that response.
And they are
right?
specifically suicide and
Correct.
crisis. Okay.
Correct. Yes.
Gotcha.
And so that absolutely is a good resource, right? Like there is nothing wrong with utilizing that resource.
Sure.
Again, if perhaps seeing your therapist out in the world, is something that's kind of holding you up, what I tell everybody, very first session I sit across from them is I tell them, if I see you in the world, I will not approach you first. Okay, you are always welcome to come up and say hi to me, but I won't approach you out at the Festival of Discovery, right? Because then you have to explain, oh,
Where do you know her from?
who's that,
Yeah,
right?
yeah.
And so, a lot of times individuals will come up and say hi, and I love it. It's great. But
Sure.
I've been in multiple situations where the other day, I saw an individual and we were both checking out at Walmart, and they kind of just gave me a little head nod, and I was like,
Nod back
and
at
that
ya.
was it, right?
Yeah.
And so know that you're in the driver's seat of that, and and so coming in and having those conversations, you're still safe even in a smaller community, right?
Absolutely.
And so, of course, always asking your, primary care provider. Again, hopefully, there's integrated behavioral health care available, like here.
Right.
But then we also have different folks, and I won't list them all, but in private practice as well, right? So a good resource for individuals who are just kind of curious, they can go on Psychology Today, because psychologytoday.com, it's a website. They even have like a find a therapist function. And so you can type in Greenwood, and any therapist who's in private practice who has a profile on Psychology Today will pop up. So you can see who's in private practice. If you're open to telepsych, you can even just put in South Carolina and you can see all the providers across the state. And so that's a really helpful way for folks to see what's available. And then honestly, there's a lot of apps that are helpful in maybe that lower level, but ongoing and as needed support. Right.
I know several people who've used like BetterHelp or
Yes.
I can't even think of the other names. No, we're not endorsing anyone specific. I'm just thinking of app names.
Yes.
But yeah, and they've gotten benefits from that. Yeah. Okay. Do you have anything else? We've ran over an hour, but it's been such a great conversation, and I hope that everybody listening, watching has learned something or thought about something, anything like that. Is there anything that you want to add to that maybe wasn't specifically asked or? Just put you on the spot.
Yeah, I guess, I think I'm hoping that individuals, right, if anything, just don't wait.
Sure.
Right.
Yeah.
Any amount, because I think about this a lot of times when we're talking about, individuals maybe who are experiencing pain, right? If you're sitting there and your back hurts, do you want to know how that impacts my back pain?
Not at all.
Not at all, right?
Right.
And so you don't have to wait for your back pain to be the worst to go to the doctor.
Yeah.
You don't have to wait for your stress to be the worst. We all know someone who has it worse.
Right.
We
right,
all
right.
know the stories that are heartbreaking that we think, oh my gosh, right?
Sure.
But that doesn't reduce
You don't have to wait
your
for it to be the
stress.
worst to get
No.
help. Just go get help now. Get it fixed sooner rather than later, right?
Yeah,
get
absolutely.
it fixed.
Yes. Well, and I've
Get it taken care of.
never met a therapist ever.
That was like, oh, you came too soon.
Exactly. Who was like, really,
isn't
this is
bad
what
enough.
you came for?
Right,
No,
right,
never.
right.
Right. Because actually, as a therapist, one of the areas that I really wish folks would start utilizing therapy more is for optimization.
Absolutely.
Like things are actually
I feel
going
great, and I want to
Yes.
keep it this way.
Correct.
Help.
And I also want to add in this thing.
Right.
Okay.
Cool.
Right? Like
That's
let's
easier.
Absolutely.
It's easier to get you from here to here than
Yes.
from here to here. And not that ease is what we're looking for, but it's
Absolutely.
easier for the person, the patient.
Yes. Well,
right?
and I want you to be well.
Right.
Right. And so a lot of times I meet folks in a level of unwellness.
Sure.
Right. And that's okay.
Yeah.
Right. But if someone is like, I just want to be more well. I'm not going to be like, nope, not today.
Sorry,
right?
I'm
I'll be
not
like,
your- not your gal.
absolutely. Come on in. Let's talk about
Yeah.
this. How do we optimize, right?
Yeah.
How do we maintain? And so I think just don't wait.
Right.
Like, just come in. Let's have a
Don't wait.
conversation.
I love that. Don't wait. All right. Well, thank y'all for listening, for watching. I'm Rachel. This is Jessica. Jessica Jacobs, our Director of Behavioral Health. And we thank you so much. And remember, don't wait. Receive help, help others, and just create those spaces. Be that safe person. Show love. I'm just giving all the sound bites now.
Absolutely.
All the bumper. We're just bumper stickers now because I'm all squishy and warm and fuzzy from having this conversation. It's a deep topic. But thanks for hanging in there with us. Again, here at Carolina Health Centers, we have integrated behavioral health into our primary care. And so we're treating the entire person. So if you need help, give us a call and we would love to help you. Okay. All right. Have a good day.